My name's Rebecca Rosen. I'm a Senior Clinical Fellow at the Nuffield Trust and also a GP in South East London. And I'd like to welcome you to this session on addressing inequalities in general practice and primary care, which is kindly sponsored by Optum. So reducing inequalities is hardwired into current NHS priorities and into the work of integrated care boards. And we want to use this session to describe the situation in relation to inequalities in general practice and primary care, and to consider, in the context of a pandemic-driven exacerbation of health inequalities, what can be done in general practice and primary care to tackle a number of key issues: the underlying causes of increased health needs in deprived populations, how to equalise access to services, and how to improve the way that we deliver services to address the complex needs, or the more complex needs, of people from deprived communities. To get the discussion going, we're starting with some short presentations taking a whole system perspective, considering the role that data can play, and this speaks, I think, very much to Bola's comments before about how we use data to really understand the issues underlying inequalities. And finally, a bottom-up lens from the front line in general practice. And to do this, I'm joined by Arif Rajpura, who's the Director of Public Health in Blackpool, Jim Forrer, who is a director at Optum, and Victoria Tzortziou-Brown, who is a GP in North East London and Vice President of the Royal College of GPs. And then we'll open up the floor to discussion after a brief detour to think about dentistry. So I'm just going to give a few overriding bits of information for those of you that aren't steeped in the world of primary care. It's now 50 years. Gosh, I can only see a tiny weeny little version down there, so I'm going to have to look this way. It's now just over 50 years since Julian Tudor Hart's seminal paper about the inverse care law, in which he concluded that the availability of good medical care tends to vary inversely with the need for it in the population served. And I'm sure you've all heard of this paper. So jump forward 50 years, and I want to acknowledge the work of one of the three Rebeccas in the London think tank world working on primary care. There are three of us, but this is work by Bex Fisher and colleagues at the Health Foundation. And she and the team there have done really fantastic work about tracking and reporting on inequalities and how to address them. So Bex has identified, she's done a review, and the team have done a review of all the policy initiatives over the last 30 years to try and address the inequalities in primary care, grouping them into four categories: contracting and payments, changes in resource allocation, investment in premises, and investment in workforce. And there are various kind of top-down methods to do with directing funding in different ways to encourage recruitment, to reallocate GPs to less well-served areas. There have also, at the same time, been a huge range of bottom-up initiatives and innovations in the design and delivery of services, which Victoria is going to talk about more in a few moments. I just thought I'd start off with a few headline bits of data about what's driving the inequalities. So first, for those of you that don't know, the Cahill formula is the funding formula through which the global sum, which is a payment for each registered patient in a GP practice, is paid. And there is no direct adjustment for deprivation to reflect additional needs. There are adjustments for standardised mortality rates and a couple of other things in each area, but that doesn't adequately compensate for the additional morbidity and the additional workload of looking after populations from deprived areas. And GPs in the most deprived areas care for around 10% more patients with, on average, 7% less funds. This is a map done by my colleagues at the Nuffield Trust, and it shows the number of GPs per 100,000 patients, the darker colour being fewer GPs, the lighter colour being more. And you can see that there are particular problems in big urban areas and then in some of the big coastal areas. And Arif, who's here from Blackpool, is going to talk to us about some of their experiences. And the corollary of that is that there are significant differences in the number of patients on the list of each GP, mirroring the number of GPs there. But actually this figure, the figure there with the highest number in the darkest shaded area being 2,800 patients per GP, is probably misrepresenting the real difference, because as there are more and more sessional doctors working who are increasingly saying, I don't mind seeing the patients, but I'm not doing the paperwork, it's the partners in a practice who are absorbing that workload. So that figure probably doesn't represent the disparities that there actually are. And then there are differences in the quality of patient experience, which is lower in deprived areas. So the bottom line of that graph is the lower quintiles, and the top line is the higher quintiles. So there's less satisfaction reported by patients in more deprived areas. Then, as we come through the pandemic with a significant increase in the use of digital technologies, there is the risk of digital inequalities. And this is a report by my colleague at Nuffield, Charlotte, who describes and sets out the potential for a growing inverse care law, an increased divide in access, particularly access to general practice, if we introduce digital technologies without thinking carefully and designing very, very carefully how we do it. We've written previously in a report about access and continuity at Nuffield that you can design carefully and thoughtfully and not end up with digital inequalities, but it has to be really carefully worked out. So I'm going to stop there. I'm going to hand over to Arif Rajpura, who's the Director of Public Health in Blackpool, and who's going to give us a top-down system perspective on the inequalities experienced in general practice and primary care. Thanks.
Afternoon, everyone. Has anyone been to Blackpool? Oh, wow. So you all know the place really well. I thought I was too far down south here to people to know about Blackpool. Before I start, just hold a framework in your head. I usually use, when I'm explaining public health and health inequalities, I usually use a framework which sort of breaks it down to short, medium, long-term actions. And if we think of it in those three time frames, so the longer term stuff is all the wider determinants of ill health, the economy, having enough money coming in, good housing, good start in life, all those wider determinants. The medium term, sort of the 5 to 10 years, that's all your lifestyle stuff, alcohol, tobacco, healthy weight, that sort of stuff. Then the short-term actions that can improve health, what I consider in my head as the sort of healthcare type stuff. So your NHS health checks, tackling blood pressure, tackling cholesterol, vaccinations, screening, all those healthcare type things. So if you hold that in your head, when we come to the last slide that I present, I think it'll help us sort of frame the policy recommendations and the asks. Is there a clicker here? You've nicked my clicker. Yeah, sorry.
Silly me.
Thanks. I have to show the tower, don't I? It's, so that's me. There we go. So the challenge from my team was to get Kermit the Frog on a slide to present at the Nuffield, which I've done. Yeah, Kermit the Frog did make an appearance in Blackpool at one of our venues. I put this slide up because you'll all know Blackpool because it's such a fun place, and we've got some of the best popular culture in the country. In fact, we are the nation's most favourite destination. We had 19 million visitors last year, so we continue to be really popular as a tourism resort. And I've listed all the wonderful things that that's the tourism plug over. But yeah, please come to Blackpool. There's lots more happening, and there's loads of additional things happening in the town. So we are regenerating the town to create those extra jobs and improve the economy, and hopefully, get away from that low-wage seasonal economy that we've had in the past, which has driven a lot of our problems. So, but there's another legacy behind all of this, and that's the deprivation. We've got significant levels of deprivation, and that drives our poor life expectancy, drives all the poor indices that Blackpool suffers from. We're a bit like a deprived inner city area on the coast, if that makes sense, because we're densely populated and with similar problems to an inner city area. So there's the sorts of things that I think I've described: the low wage economy, low educational attainment, poor housing, a seasonal economy, child poverty. All of those things are things that blight us and are things that we need to address. But as I said, there's lots of things happening in the town. We've got lots of HMOs. By that I mean houses of multiple occupation. We've got 3,500 to 4,000 HMOs. So that's probably a bit more unique to us and to other coastal towns. And what that does is it drives a level of inward transience. And I always describe it as we end up importing ill health and exporting good health. So when you go onto Zoopla and you want a cheap place to live, Blackpool comes up. So people turn up to Blackpool because they've had a good experience as a child, they're running away from something, they end up coming to Blackpool to run away from their problems. But people with vulnerabilities that end up in our town, there's lots of people to prey on those vulnerabilities. So if they've got a drug problem, got an alcohol problem, or they've got any other problem, we've got all those people to prey on that vulnerability. So putting lots of vulnerable people into an area isn't a good idea because there's people there to prey on that vulnerability. So HMOs, 3,500 to 4,000 HMOs that drive that inward transience of ill health. And I'll come on to that in a moment because there's some really exciting stuff we're doing around the HMOs, which is one area. So if you said to me, amongst the wider determinants of ill health, what would you want to tackle, Arif, in Blackpool? I'd say I'd want to tackle the HMOs because they are causing a significant problem, both from the direct poor quality of housing resulting in people having ill health, but also the transient element as well. So that is the private rented sector with the HMOs. So it's not the social housing that's the problem in Blackpool, it's the private rented sector. But the problem that I have, we could do so much more in Blackpool if we had the money. So we've been cut, and local government particularly has been cut, and there's been a decade of underinvestment in the NHS. So my local authority has had one of the highest cuts per head of population. So one of the most deprived local authorities has had one of the highest levels of cut per head of. How can that be fair? Why are we not shouting about that more? So it's had the cuts have had a disproportionate impact on areas like mine. And there'll be other deprived authorities who have had similar levels of cuts. And we can have a discussion about why that may be. Also, the government shelved the Public Health Inequalities, the Health Disparities White Paper, which it was due to publish. I think it's going to be a major conditions white paper now, but they've shelved. So we don't really know what the government's plan is around prevention. And things like minimum unit price, stopping junk food advertising, increasing the age of sales tobacco to 21, all the Khan review stuff, we know, all that good stuff that we need implemented that will improve population health. The government doesn't want to talk about that at the moment. So that's the other thing from my perspective that we really need to start to discuss. Those population level policy decisions government can implement that will improve the health of the population. Then we've got this thing called Levelling Up, and Levelling Up has arrived in Blackpool, and we've been funded a couple of big essential infrastructure projects we've had money for, but it doesn't make up for all the funding that we've lost in the last decade. So we're really grateful we've got that, and that's brilliant, and we're really happy with that, but it won't make up for the funding we've lost. And the other thing it doesn't do is the stuff that I want to do around the public health agenda and the people interventions. We haven't been funded that. So I've been having a discussion with the Department of Health and DLUC to say, look, it's great that you're funding these essential infrastructure projects, these big capital projects, but give me some money. I want you to give me some of that money that you've taken off me back so I can do all those great public health interventions, all those evidence-based things that I can deliver on the ground and me and my team can do. So that's what's lacking in the Levelling Up, the people bit of the interventions. Going back to the HMOs, there's some exciting game-changing stuff happening around the private rented sector, around houses of multiple occupation. We are working with government on addressing that issue, both by stronger enforcement to decent home standards rather than minimum standards, which is what we can enforce to at the moment, but also significant capital monies hopefully coming into Blackpool to convert those HMOs into family homes and to reduce the level of transience happening in the town. So that's just a little bit of context on Blackpool, and it'll be similar to other areas. In terms of the policy recommendations, if we're going to talk about levelling up, we need to level up public health and primary care. So we need to increase the resources in primary care. And by that, I don't mean just GPs. I think a colleague talked earlier about social prescribing link workers. I think these are really important. And the ICBs need to get into a discussion around how they resource all of these in their places. So the place, I've still got another 15 slides. Sorry, I'm joking. They need to think about the deprived places within each ICB and how they resource that appropriately with social prescribing link workers, and using social prescribing link workers from the local community. I think that's really important. People with lived experience being part of that. I could do a lot more. We do a bit of this in terms of integrating all the public health services that I commission with primary care, but we could do far more, and we could incorporate housing support, citizens' advice, all of that into the mix if we had those resources. The thing I will say to primary care is that we can't continue to have a model where we're expecting people to turn up to the GP practice for their preventive services, because often they don't from the deprived communities. So the thing I learned from the pandemic was we had a vaccine bus going around Blackpool delivering vaccines, no appointments necessary, you could just rock up, get your vaccine done. That wasn't delivered by the NHS, that was commissioned by the local authority, because we were worried about inequalities around vaccine uptake, and that worked really well. So I'm going to be using that model to deliver NHS health checks, a more mobile outreach model. So we need to get into a discussion with primary care about how we actually deliver that. And my last point, before I get thrown off, is the sustainable VCFS sector. If we're going to address some of the needs around our population, our social prescribing link workers will need somewhere to refer those individuals to, and often our VCFS sector is seen as being for free. Well, it's not for free. We need to fund it. We need to fund it properly. We need to fund it on a longer time frame, because they're doing some amazing stuff. And I've been working with the sector more recently around the cost of living interventions, and they've been delivering some really good stuff on the ground. So we could do, again, far more if we had a sustainable VCFS sector. I think that point's been made already. I'll stop there. Thank you.
So next we're going to hear from Jim Forrer, who's the director at Optum, who's going to give us a perspective on how we can use data to better understand inequalities.
Thanks. Hi everyone, thanks very much. I'm a GP as well as being a director at Optum, and I wanted to start by telling a patient story about, let's call him Bob, who came up to the practice. The practice is a bit outside the centre of town, having moved to a shinier building. He lives under a bush outside the library, literally, and some of his peers had become extremely worried about how he was acting and how he was feeling, and he really didn't seem right to them. They were able to let a local charity called Gateway support him by paying for his taxi up to see me. And when he attended, he smelled very strongly of alcohol and cigarettes and was incredibly polite and talked to me about his symptoms, and I did some checks on his blood pressure and those kinds of things. And I felt he was very entrenched, if you like, in his life in the town where I work. And I wasn't sure, and I thought, well, what would I do for this person if they were white and middle class? Sometimes those kind of questions, as you observe yourself practicing, do come up. And I thought, well, I would definitely send them to hospital, because whilst I'm pretty sure he's okay, given all that he's going through, the substance misuse and the alcohol. I'm really concerned about him. And when I mooted the idea with him, I don't think I've ever been sworn at so politely. There was absolutely no way he was going to hospital. And he literally said to me, "I'll tell you what I'm doing next," very kindly and politely. "I'm going across the road to Waitrose to buy more alcohol for the rest of the evening." I had been able to reassure him that I thought, on the whole, I thought it'd be fine. And as he left, I thought how far away he is from a lot of the concepts we discuss and I discuss, and any kind of data model. We're not likely to pick him up and his needs very easily. There are estimates made, but there is always going to be a limit to what the data can give us and what the data can tell us. And I think we always need to be mindful of that, and I'm sure all of us are in many ways, but that was a real single example where I felt no matter how many dashboards I see or help produce, that kind of person is always going to be difficult to reach. I wanted to talk a little bit about the way we use data and what the index of multiple deprivations are that we use really as our definition of deprivation. So the index of multiple deprivation, as many of you will know, is split into 10 deciles in rank, and they relate to what are called lower layer super output areas. I'm not actually any kind of expert in this, but I have done a bit of preparation for this, you'll be pleased to hear. So each one of those is about 650 households and about 1,500 people. So that's quite a few, and comprises a mix of contributors, because deprivation isn't just money in your bank account. But it's weighted in descending order to income, employment, education, health and disability, crime, housing and local services, and living environment, because you're deprived if any of those aren't as good as they could be for you. Interestingly though, there's health. 13.5% of that is health. So I looked into that a bit more, and health there is defined as, so your deprivation goes up on these features for people in that area who die before the age of 75. So the number of years they could have lived up to 75. The number of people on illness or disability benefits. Interestingly, the number of inpatient admissions. So there's this kind of circular thing going on there when we consider how deprivation links to admissions. Medical admissions relating to mental health. Prescriptions relating to mental health. And suicides. And that's all done historically, so usually in most of those data sets pre-2017. And as I learned about those things, I realised that's still really broad, and many people and many of the public health colleagues in the room will be aware we really have quite a crude way, arguably, of counting what deprivation is. General practice in primary care deals with individuals on the whole, and data can bring us from the individual, ideally, right up to the system, but we need better data to do that. And in any PCN, mostly, they will know which practices within that PCN are facing the real issues that are in the centre of town, that have maybe the most people with dual diagnosis, mental health and substance misuse issues, and are facing those deprivation issues. But there's very little incentive, really, for those practices to help each other out at the moment. So perhaps there's something about bringing the local knowledge together with the local data and helping PCNs to support their practices over that area with the deprivation they face. But trying to relate that data model to images of of people, what do we mean? What do we think of when we described the deprived or the more deprived people? We know statistically, in some of the work I've done at Optum, evaluating statistics and analysis of data that we get, is that those people are more likely to be obese, to smoke, to be drinking, to use drugs, to be on antidepressants, to suffer anxiety, to be on higher doses of opioids, and to have more illness. In one analysis we did, we found in the lowest quintile of deprivation, people suffered an illness burden in their 40s, equivalent to that of people in their 60s in the highest quintile of deprivation. So to understand these people better, we can better understand where else they're getting their care from, where else they're getting help with their needs. So by linking data around, we get a more colourful picture of who these people are, when they're calling 111, calling out ambulances, visiting outpatient appointments, etc., etc., all those different areas. Sometimes when you see that represented in what's called a theograph, you often see that really meaning a lot to the people that are viewing that, because they see, oh yeah, I only see them when they come into, see them when they come into my building through my doorway. And that's a little bit of an issue with the NHS at the moment, is that we've got this brilliant free at the point of care, but it's pretty flat. It's free at the point of care if you can get there and if you understand how to get there. Arguably, it's a beautiful idea and a beautiful principle, but to improve health equity, we need to be reaching out. We need to be proactively going outside of our doorways, linked with the other areas that people seek help from. So that lowest quintile, that lowest decile, they might find it difficult to articulate their needs in the same way that other people, more educated, arguably do. They might find it more difficult to read the letters we send them, to understand the complex ideas we present to them and the complex letters sometimes we send them. Sometimes they might find it harder to gather motivation, to make the commitment and find the organisation in the face of their chaotic lives to make that appointment. They do miss more appointments, for example. They might have less access to travel and transport. And so what can we do for them? What does all our conceptual and analytical and database talk, what does it boil down to? I think it boils down to things like listening more, spending more time to understand, giving clearer information, supporting people with, might be text reminders, it might be telephone reminders, making care more available to those people and giving proactive support, maybe with a named person they know that's dealing with them. It might be social prescribers, those kinds of things, but it's about relationships, and it might be earlier support. So that's about prioritisation, that's about allocating resource to members of our community differently, because we know that they deserve it, and we know that the system will benefit. To Bola's comments earlier, we know that urgent care is of higher usage in that lowest quintile. And so by giving that resource, we can release resource in other parts of the system. So we need to build relationships and understand and accept the differences between the us's and the them's. That's the classic primary and secondary care, mental health and physical health, and social care and healthcare, but also between us and the lowest quintiles in our communities. We need to show people local data. So we see the Tudor-Hart inverse law, and something somewhere, I think, says, probably not in my area, even though we know it is, but when you show people in your area, in your GP practice, in your PCN, in your hospital, this is what's happening, people really wake up. Inequalities are a great unifier across disparate systems looking for integration. Inequalities is a brilliant shared purpose to bring people together. We need to join with the VCSC communities. They really know people in their communities. Through interviews I've done, I've really learned that though I think I've got an intimate relationship with my patients in the sense that I see them from cradle to grave, I have a continuing relationship with them. But the VCSE sector sees them in their homes, in their communities, in the estates, in the parts of town, and that is really eye-opening. So those relationships need to be bonded more closely to help people better. But the data, ideally aligned around patient-reported outcome measures and patient-reported experience measures, allows us to know who we're talking about and who in that group needs to be helped first. It allows us to predict the benefit that we can gain by helping them now, to make that important business case. And if we're making a business case or making an argument for the feedback loop, we can say what's in it for you. About 20% of A&E presentations or emergency presentations will result in a contact back to the general practice they're part of within one day. And I know late in the evening, trying to deal with discharge summaries and rationalise the medications, check they're on the record, make sure the diagnoses are coded, and arrange follow-up. Emergency admissions, as a single example of what we want to mitigate, create work for general practice. We need to use the data to bond people across organisations so that they see that it's a problem for all of us, and we all benefit if we tackle it. Thank you. So the way we do that is to create the space to act, to empower practices to know that they'll be rewarded for spending the time that's needed to concentrate on deprivation, to know there's a return, and to know that work is incentivised appropriately, and to create a PCN view, a primary care network view, that allows us to bridge across that practice that deals with the more deprived part of the area and make that the problem for the wider community encompassed in the primary care network. But most importantly, I think it's about aligning that local knowledge to the data sets we can create, and linking those data sets gives us the best and most colourful view of the patients and people that we want to help. Thanks very much.
Thank you. So that very rich picture of what creates some of the additional need and the challenges leads very effectively, I think, into Victoria's presentation. So Victoria, GP in South East London and Vice Chair of the Royal College of General Practitioners, is going to talk about some of the initiatives that have been put in place within practices to tackle the kinds of problems that Jim's described. Thank you.
Thank you. I hope the slides will come up. Thank you. Thank you for inviting me to give an overview of the initiatives that have already been tried within general practice in terms of tackling health inequalities, but also bring some of my own reflections in view of my previous role as CCG Integrated Care Lead and co-chair of the RCGP's Health Inequalities Group, and more recently as a researcher on the impact of our remote working within general practice on health inequalities. I have been working as a GP in East London for 20 years now, and it's a wonderfully diverse area, but also has high prevalence of multimorbidity, childhood obesity, and poverty. And East London has some of the most expensive riverside apartments and also some of the most deprived neighborhoods side by side, sometimes a street apart, where differences in healthcare access, experiences, and outcomes can be stark. The drivers of health inequality are not necessarily the same in urban and rural areas, and health and care needs vary not just between geographies, but also within groups of people who share very similar characteristics, such as the same ethnicity or the same deprivation score. Therefore, tackling health inequalities requires both a national and a local approach, and interventions need to be implemented at both population and individual patient levels. And I think this is where the strength of a well-resourced general practice lies. So an example of a bottom-up GP initiative to tackle health inequalities is, of course, the Deep End movement, which started in 2009 and included the 100 practices with the highest proportion of deprived populations. The movement created a sense of identity and opportunities for shared learning and support amongst practitioners in deprived areas. The Deep End project used a series of successful interventions, including the introduction of longer appointments and protected time for GPs to engage in joined-up care for patients with the most complex health and social care needs, community link workers, mental health and welfare advisors in practices, access to localized data that helped identify unmet need and also encouraged appropriate use of services, and GP fellowship programs to improve recruitment and retention in deprived areas. And of course, the Deep End project has expanded across the UK now and also internationally. Within England, we have had the development of the Core 20 plus 5 NHS initiative, and I know Bola is here, so I need to get this right. So the initiative defined a target population based on deprivation and also other locally identified needs, and focused on five clinical areas requiring accelerated improvement and proactive care. And a similar approach has been developed for children and young people. As part of the initiative, there is funding for place-based recruitment and support of community connectors. PCNs, primary care networks, have nominated health inequality leads, and in a similar way with the Deep End project, there is an expansion of the GP teams to include social prescribers, care coordinators, and health and well-being coaches. In addition, there is a plethora of other local and national initiatives. These include the co-location of health and well-being services like the Bromley by Bow Centre, and I know Sam is here, offering GP services alongside a range of activities for all ages, including gardening, training, computer skills, creative arts, and adult social care, and creating a truly healing space. There are GP local incentive schemes providing extra funding for care planning and multidisciplinary working. And in addition, there are educational and training initiatives, such as the Safe Surgeries Toolkit, which aims to improve GP registration, and the Fair Health Trailblazer program, which offers fellowships to early career GPs aiming to recruit and retain them in under-doctored and deprived areas. And also, of course, a multitude of e-learning modules on health inequalities and inclusion health. Access, experiences, continuity, and consultation length are important considerations for all general practices, but seem particularly relevant in areas serving populations affected by health inequalities. In terms of improving access, it seems that we should not be aiming for equal, but for equitable and fair access. In other words, we need to be able to tailor access to the patient's individual needs. So, for example, reflecting on some of my work with people from inclusion health groups, many of the participants mentioned barriers to access because of digital exclusion. However, there were also some who actually found remote consultations easier for certain problems. Therefore, giving options seems important. And also developing more sophisticated triage systems so that we can prioritize based on clinical need is also necessary. But it is not just getting an appointment that matters. The experience of the process matters too, and needs to be guided by trauma-informed practice. The recognition that for some of our patients, seeking medical help requires a significant amount of effort and courage. And what we say in our interactions with them can make all the difference on whether they will engage or give up. And staff experiences matter too, acknowledging that working in deprived areas is challenging, both because of the medical complexity, but also because of the psychological impact, and colleagues in these areas need to feel supported by the system. The value of continuity of care for populations affected by health inequalities has been highlighted in several publications lately and resonates with most clinicians. When we know the patient, we better understand the challenges they face, and this seems to help them to disclose potentially serious problems earlier and enables better shared decision making. And there is also some evidence that when there is continuity and trust, remote consultations feel safer too. And finally, consultation length was mentioned under the DEPEND initiative, but I added it here too because I wanted to emphasize that it can be incredibly challenging to provide holistic care compassionately when seeing 50 to 60 patients in a day. Such workloads are adding to our workforce retention challenge in deprived areas and need to be addressed. So there is a plethora of interventions that are available and can be delivered at GP and primary care network levels. These, of course, require extra resources, including an expansion of the GP workforce, but at the same time, I believe that the implementation of these initiatives can assist towards improving workforce challenges because they can result in more fulfilling careers. Reducing inequalities in GP access and experience is relatively straightforward with the right resources and workforce. I'm aware I got carried away with the shapes and colors in this slide, but I really wanted to highlight the range of the wider determinants of health that make narrowing inequalities in healthcare outcomes a lot more challenging. And I think this requires a close working amongst multiple actors, both within and out with the healthcare system. General practice has an important role to play in this, and the developing integrated care systems and place-based partnerships present opportunities for taking this work forward. Thank you.
Thank you. So I hope you've got a rich sense of both the determinants of the inequalities in general practice and primary care and some of the potential for addressing them. Just before we open the floor for questions, clearly the headlines in the last few months have been full of appalling stories about dentistry, and as one of the primary care contractor services, issues around inequalities in access to dentistry are really significant as well. And we have Edward Crouch in the audience with us. So I've asked him just to say a few words about how the issue of inequalities is playing out in the world of dentistry. Edward, thanks. Over to you.
It was only my mother that called me Edward, but I'm obviously done something wrong. Most people know me as Eddie. It was interesting to hear Nigel this morning talking about the privatisation of the NHS, and we hear about industrial action in the NHS. My colleagues on the High Street are taking industrial action by moving away from the NHS, sadly, at the moment. Access, as you rightly say, through the pandemic was terrible. Especially for dentistry with aerosol generating procedures. Mm-hmm. We lost about 40 to 50 million appointments during that period of time, and we've got ongoing problems now coming out of the pandemic. We had lockdown diets for our children, sadly. We had suspension of public health programs, and many of my colleagues on the High Street are seeing much worse presentation of dental problems into their surgeries. The BBC carried out a research in the autumn of last year. They contacted about 96% of practices. Sadly, only 1 out of 10 were accepting adult new patients, and only 2 out of 10 were accepting new children. One of your colleagues there was talking about the inequalities of travel. If people can access dental care, often they're having to travel huge distances to do that, and that it creates itself inequalities. We've done quite a lot of work recently with some charitable organisations, and one of them recently did a survey of school teachers. We've got the perfect storm, really. We've got the problems with access, but we've also got the affordability of dental treatment outside the NHS. And 4 out of 5 teachers polled had given some children in their class toothbrushes and toothpaste because of the levels of inequality within that. 25% of teachers had said they'd had children missing time from school because of dental problems, because of oral health issues with pain, swelling, infection. We saw from figures recently released that general anaesthetics for the 6 to 10-year-olds going in to have teeth taken out in hospitals is still the most common reason for children to be admitted to hospitals. And you're 3.5 times more likely in a deprived community to have teeth removed in that way than if you are living in a well-remunerated area. We have seen a lack of a national strategy on prevention, and we've got people on lower income with no option. If you're affluent, you're 6 times more likely to be able to afford private dental care. NHS dental charges before the pandemic were rising at 5% per annum, much more than inflation, and that in itself created health inequalities. Many patients believed that increase in patients' charges was actually going to the dentist, but it was coming from what the Treasury was subsidising dentistry. And dentistry is the one area of healthcare that has seen a net reduction in funding in the last decade. Sadly, patients are making decisions about their own health based on their ability to pay. We talk about the NHS being free at the point of delivery, but dentistry has not been free at the point of delivery for a long time. And even those who are exempt from dental charges and receive free treatment, in fact, I was talking to someone at lunchtime who's pregnant who found it very difficult to get the free treatment that they're entitled to. They're unable to access the care. Thank you.
Thank you for that very depressing overview of, but absolutely essential to acknowledge it, because it has been an extraordinary failure of supply in the last increasingly, but certainly hitting the headlines in the last year. So I want to open the floor up to questions, and perhaps one challenge. I started off with a cutting from a report about 30 years worth of policy initiatives. We've had some fantastic suggestions about things that can be done. And thinking about the session this morning, maybe some of you have got thoughts on what is it that is stopping the plethora of policies that we know should be in place and sometimes are in place from working. So I park that with you. Anita's got her hand up first, so Anita, and then I'll come to others.
Thanks very much. Anita Charles from the Health Foundation. And I wanted to talk about two things, three things actually, that didn't come up very much in the very wonderful presentations. One was the work we've done showing that already in more deprived areas, the skill mix in primary care is significantly different from the skill mix in better off areas. In other countries where they've struggled to get the equivalent of GPs to move to some of those areas, what they've done is embrace the fact that actually you need to change the skill mix and provide a different sort of potential model of primary care. And I'm very interested in the questions about dentistry and elsewhere about whether or not actually in some of these areas we need to think more radically. And what we're trying to do at the moment is make areas fit. So that was one question. The second one is, if we're going to do anything around this, you've not talked about capital. And yet, the premises and the physical facilities to actually embrace these sort of needs is really important. And the third thing is recognising the importance about continuity and coming back to the very important point about HMOs in Blackpool. I was on the board of a PCT in London for a number of years, and our problem wasn't HMOs, but it was that families were often on very short tenure and were moving a lot because they couldn't get into social housing, but their ability to secure really reliable housing was very, very limited. Now, in many parts of the country, poverty isn't associated with housing problems and housing movement, but in lots of the country, poverty is associated with lots of movement. Because our system is so micro-geographical based, what that means is if you end up moving a lot, you sacrifice continuity. The very people who are likely to need continuity most lose that. So I guess my challenge for the panel is, are we being radical enough? Yeah? Or are we trying to make people fit the existing model, and should we be being more radical and more challenging?
Thank you. I'm going to park that for a moment and gather a couple of other questions and then come back to the panel. So I think, Kieran, you had your hand up, and then there's somebody just sitting behind Fiona there. Kieran.
Yeah, hi, Kieran Patel, Medical Director at University Hospitals Coventry and Warwickshire. I guess just to build on that, I think our challenge is to be more challenging, and it's great to hear public health, primary care and EDI speak, because I think patients don't suffer from inequalities in just mental health or physical health or dental care. They all go hand in glove. So our challenge is to really make health equity everybody's objective all of the time, because unless we do that, we fall over. So we need to make the puzzle complex but address it all. And in fact, even in the acute trust, I've appointed a public health director and a GP who have really challenged the way in which we think. And it's catalysed a fantastic way of thinking, because we've got to veer away from just talking about inequity of access, because the way that we think about access at the moment fuels inequality. So if we just focus on waiting times or DNAs, we actually fuel the way in which we do business to drive inequality. We've got to start to focus on health outcome equity, because we're very good at just measuring what we can measure rather than doing the complex. And in fact, we had an outcomes framework many years ago, but what did that drive in terms of a health inequalities dimension? So I think we've got to get to a point of being much more challenging to ourselves in terms of the collaboration, not just make it the business of public health or primary care to generate health equity, but actually for all of us to work collaboratively to it. Because if we don't do that, I suspect we will fall over. So how do we develop architecture and definitions to help us to do that, I think, is our greatest challenge.
Thank you. There was a question just at the back there, and then I'll come back to the panel.
Thank you. I'm No.
Yes.
Hello, so I'm Kerry White. I'm the Managing Director of Symphony Healthcare Services. We're based in Somerset and Devon and have a number of general practices within our organisation. So thank you for that great presentation. I just wanted to ask a question as to whether the panel think that primary care networks are the right model. A lot of fundings obviously come in that direction to address the inequalities in primary care.
Thank you. And I've realised I failed in my duties as a chair. I've got about 15 notes here, and one of them was meant to say, when you ask a question, can you please stand up? So that the people who are filming at the back can see. So anybody else who asks a question, if you could stand up and introduce yourself, that would be great. Okay, over to the panel. So there's lots of different themes there. Skill mix and how to push that further, capital spending, continuity as a challenge with people that are very transient, issues about building a system architecture of collaboration focused on outcomes, and then are PCNs the right model? So I'm going to leave you initially to pick your area to respond on. Who'd like to go first?
Can I pick the HMO one?
You can.
Yeah. So what can we do in that area? There's a couple of things that we're doing with government at the moment around HMOs, which is, at the moment, private landlords have to only meet minimum standards. They don't have to meet the decent home standards. So we're looking to enforce decent home standards. The other thing we're looking to do is to knock down loads of HMOs and build family homes. I guess that's the biggest strategy. The other thing that we're doing as a local authority is becoming a landlord. So we've created an arm's length company which is buying up these properties in Blackpool, and we're becoming a landlord. So not just for the social housing bit, but for the private rented sector as well. So we have more control over actually that issue around tenancy. So that's the housing bit. The other bit that was picked up on was around I guess it's back to integration, isn't it? A lot of the stuff that we're talking about, it's about connecting the services that we have already available in the community, in the voluntary sector, the stuff that I commission, the stuff that the NHS provides, putting it all together and making sure it's connected. So the thing that I try and do in Blackpool is I try and be that glue if I can. So bringing various partners together to actually discuss this. And I've really found it valuable when I've got all the partners in the room on a regular basis, because that's actually practical integration. People talk to one another and start to understand what each bit of the jigsaw is actually delivering, and then they know who to connect to. So I know that sounds really resource intensive, but I do that every 2 months of bringing loads of people into a room just to chat. It was done on the basis of cost of living earlier in the winter period, but bringing people together starts to connect people. It is resource intensive, and it takes a lot of time and effort, but it is a useful exercise. It builds a relationship. And I also then have a monthly call with the voluntary sector to make sure everyone's connected and in the same space.
Just before we leave the issue of transience and continuity as well, that people's universal access to their medical record now will at least give continuity of information that they can carry with them. But I think it does raise really interesting questions, which I think one of you two, I can't remember which, said actually making contact outside of health services. And maybe we need some kind of other health centre point in areas with high deprivation, so that there is a connectivity where you can have continuity even if it's not with your GP, or we challenge catchment areas as another way of thinking about it. Right, which one of the topics would you like to pick up on, Jim?
I'll pick up on a couple. The workforce one I think I'd like to speak to. Currently we design our workforce largely around data that's involves coding of diagnoses for the most part, which isn't the language in which patients use in the most part to tell us about their conditions. Sometimes they'll say it's arthritis. They'll usually say what they're feeling and what they're experiencing. And we can do better at codifying and understanding that and creating a data set And those issues that patients present with, that's the actual input. From my perspective, I'm talking about general practice and primary care. That's the input that goes into the processor that is primary care or general practice. So we're not really measuring the actual inputs. We're measuring the variably coded outcomes. Once you start to build a data model of what people are actually concerned about, they're overwhelmed, they can't cope with their spouse's behaviour through to dementia or whatever it might be, can't cope, attacked by cockerel is one I've had, or sticking out belly button is another. Whilst they're trite, they represent the kind of language and needs that come down the phones and sometimes down the digital tools. Once you've got those, you can refine them, codify them, and match them against a workforce. And you can see what kind of workforce will support those kinds of needs. And I think that's an enrichment of the data that we can encourage and develop. There's an interesting question about whether PCNs are the right model. I used to chair a federation for a couple of years, and I think PCNs, if you want an equality across the country, nationally, you'll need some kind of statutory body from which to flow funds to enable change that isn't lying within a practice boundary. That doesn't always get you the outcomes you need. And areas that are lucky enough to benefit from either a federation or a combining organisation, such as Symphony, are lucky, and you can see why they might be agents of more change and arguably more control. So I think that's the tension there, is managing the areas that don't have that opportunity. Whether we can design policy flexibly enough to incorporate the strength that those organisations have against the equality you can create as best you can through primary care networks, I think is the challenge, creating a flexible system around the flows of funding. I think I'll leave it there for Victoria to take on.
Thank you. Victoria, any comments you want to make?
Yes, regarding the skill mix, I absolutely agree that it has to be beyond general practice, and I think that's why actually there is an investment in additional members of staff, and I mentioned the examples both in terms of the Deep End project with link workers and welfare advisors and mental health advisors within the practices, but also increasingly within primary care networks. We have all sorts of new health and care professionals joining our teams. With regards to PCNs and whether they are the right model, where I would agree that we need a model there where the funding can come through. At the same time, we need to allow the primary care networks to innovate. They are probably the right size to allow relationships to develop within a neighborhood, and these are really, really important because health and care professionals need to work with their communities and the local VCSE organizations and with local representatives of the local authority. So therefore, it is a good, I think, model, and we should invest on it, but we should allow flexibility to local primary care networks to innovate. Yeah, I think I will stop there.
Thank you. I feel like we haven't really addressed Kieran's question about a collaborative system architecture that's focused on outcomes across many different areas. And I guess we haven't really got an ICB or ICS perspective up here. And so if any of you out there have got thoughts about how ICSs can contribute to better outcomes across the whole primary care landscape, then do throw them in. And I was aware that each of the speakers really talked about the need for the loss of resources and the need for more resources, and a question about how are we going to get them? How can we get them prioritised in the context that we're in now for addressing inequalities? Yes, Stephen.
Thank you, because I'm responding to your challenge, not because I'm involved in an ICB or an ICS, but because the conversation as it's gone on today, I thought was encapsulated by Victoria's last slide, which I'm sorry you took down before I could draw attention to it. Because what it did was to go back to the discussion we started with this morning, all the different influences on health, and challenged us to think about the core question underlying so many of our conversations. Are we discussing the management of a bureaucracy called the National Health Service, or are we discussing the health of the citizens of the country in which we live? And they're two very different questions, because Sarah Pickup earlier this morning was the sort of one representative who spoke up for local government. I'm not sure how many other representatives there are in the room who can speak with authority to the issue Arif was discussing, which is the impact of housing on health. One of the slots on Victoria's slide was green spaces, the ability of people to live in healthy communities. And I think it's perhaps a challenge for the Nuffield Trust to be clear whether this summit, which I think is one of the best I've attended, is about health, or is it about healthcare systems? And the healthcare systems, is it about health or is it about healthcare? And one of the tensions that underlies all of these conversations, I think, is that we all embrace the principles of the National Health Service, but we keep tripping over the fact that the National Health Service itself gets in the way of delivering the objectives that it's very good at articulating. And that's the tension that I think we need to start to tease out.
Nigel ran out of the room when you asked that question. He's back now, but I don't think he heard the question, and he's leaving, so we'll leave it to the next person. The woman in the, so I'm resorting to the fashion descriptions here, the multicoloured top.
Thank you very much. Genevieve Small, I'm a primary care medical director for North West London, and I'm a GP in Harrow. And I just wanted to, I thought it was really helpful, Jim, to hear the articulation of what the factors are for the deprivation index, because I think it's really important that we understand what it also doesn't include. So I'm a GP in Harrow. Harrow is not, sadly, the posh school on the hill, but it does count as a 7 in the deprivation decile in many of its parts, which is obviously very, very good. But it doesn't include the fact that we have a great spread of ethnicities. English isn't the first language of a lot of our residents. We have people who are paying a lot in their rental income, so they have very little disposable wealth. And picking up Eddie's point about dental decay, we're the worst borough in London, with 42% of our under 5s with dental decay. So my question is, whilst we're doing this fantastic work, which I'm completely up for, and I think the Core 20+5 is a great incentive for that, how do we make sure that whilst we're looking at those areas, we don't also let other areas slide because they're not in the bit that is the trendy bit? If I want to, that's a terrible word, but do you know what I mean? Just kind of like, because actually when you start looking, as we all did in COVID in the vaccination program, you see deprivation, you see inequalities everywhere, and we all want to be part of that journey.
So I'm going to ask each of you to respond to that, because I think that is a really fundamental question about how we're going to tackle inequality. So over to you, and then we'll have to wrap up. So Arif, do you want to go first?
Yeah, I mean, in terms of tackling inequalities, for me, I'm trying to improve life expectancy in Blackpool overall. That's my task, and improving healthy life expectancy. That's the challenge that we've got, and as I said at the start, I think there are various interventions that we need to put in place, short, medium, and long term, the way I described them, to actually do that. You're right about just not focusing on Core 20+5, because what about the early years stuff? You know, the 0 to 5 stuff, because a lot of the problems are laid down, you know, by the time kids go to school. So all that school readiness piece, I don't think we're giving that enough time and attention, because it isn't seen as a priority. But if you ask Sir Michael Marmot, you know, if you just pick one thing, what would you do? Well, he'll say, do the early years stuff, because that'll give you the biggest benefit in the long term. Won't hit any targets in the short term. That's long-term stuff. So I try and think of public health in a multiple way, so that you can achieve some things in the short term. but then not take your eye off the longer term programs?
Thank you.
My answer is build as good a data model as you can. Perhaps I would say that, but I do believe it. Because the better your model is, the better it reflects reality, and the better you're understanding the population, and you can ideally see where you can make the most impact and how much pain and suffering you can relieve with the most minimal effort and the greatest efficiency, which, as Bala said earlier, is often around redressing inequalities and often reducing improving safety. I'd say it's about using that model, that better data-fueled understanding of your populations, to build relationships around the unifying concept of reducing inequality. So build better relationships across historical boundaries. To consider deeply, which has been mentioned a few times now, the wider determinants of health and reduce reliance on a biopsychosocial model, and certainly be proactive in your care. Reduce the predominance of reactive care that causes burnout, stress, and perverse behaviours, compared to taking action to reduce the burden in the future by acting now and earlier. And finally, I'd say on top of those things, that little ask is to align incentives with the outcomes that we want throughout. Ideally represented by ideally representing outcomes by what the patients say is pleasing and beneficial to them, with a healthy understanding of what is right in all the ways we've discussed. So aligning incentives to outcomes is the overarching thing.
Thank you. And Victoria, final word to you.
Thank you. I would say that health inequalities, first of all, are everywhere. Even in places where there is no deprivation, because deprivation is one factor that causes health inequalities, but not the only one. I will tie this to the role of the ICSs, how I see it. And I see ICSs as the facilitator and connector, rather than the body that creates the solutions and then tries to implement them top down. Frontline staff, health and care staff, need to feel empowered by the ICSs, by the system, to do the right thing, to work with their communities. And I think if we build on that, and if we assist them to innovate and evaluate what they do, and then share the learning, that will be very powerful. So I would say that what I see the role of the system is probably to empower frontline staff, support the workforce, in order to be able to, in turn, listen to our patients and our communities.
Thank you. I was going to try and do a really quick kind of summing up, but actually I think that those final comments have illustrated that actually the approach to tackling and reducing inequalities is not so different from that very complicated map that Nigel put up this morning. There is no single magic wand. There are several strands that we have to pursue at once. And I really want to thank the panel for their deep insights into, and their experiences, sharing their experiences about how we can go about this. So will you join me in thanking them? And then I've got some very important announcements, which I will... So I've been threatened with death if I don't tell you, and I've got mime support at the back here if I forget. So there is now 1.5 hours of, 1 hour and 20 minutes of time to go and check in, which starts now if you're staying overnight, networking, relaxing, catching up on your emails or whatever. And the reason it's only 1 hour and 20 minutes is because at 6 o'clock, Sean Linton is going to be in conversation with Leonora in here, but you've got 10 minutes before that to go into the bar, which is over there, and pick up a drink so that you can come in here clutching your drink and listen to what will be a very interesting conversation. For those of you who aren't staying overnight and who are leaving today, please would you fill in a feedback form? It's really important for us to know, in terms of designing the future events. And if you can thank me again, if you can join me again in thanking this panel, but also everybody who's contributed today to what I think has been a really incredibly varied day, from high level, more conceptual stuff to very practical and applied stuff. So thank you again.